Okay. So good evening. Thanks for joining this webinar. So I'm Joseph Dottino. I'm one of the gynecologic oncologists here at Beth Israel Hospital. And our webinar tonight is going to be talking about fertility sparing management of endometrial intraepithelial neoplasia. So I'll go ahead and get started. And I'm hopefully I budgeted this well so that there'll be some time for questions at the end, and I think there's a chat too. We can ask some questions in as well. So feel free to do that. Let's see. Oh, okay. All right. So if you know me, you know that I moonlight as a cartoonist, and I have hundreds and hundreds of rejected cartoons, that some of which are applicable for talks that I give, and I thought this was appropriate here. So in this one, there's a old-timey executioner with a man, and he's saying, honestly, I really wanted to be a butcher, but even the entry-level positions are like experience required. So when we hear endometrial intraepithelial neoplasia, as we'll talk about, it's a cancer precursor lesion. And so as a surgeon, my initial thought is always to cut it out, to remove it. But, in these cases, there are other options, especially trying to align with the goals of the patient. And those instances are either going to be in terms of it medically doesn't make sense to go to the operating room, or as we'll discuss, with the goal of preserving fertility. Let's move my thing over. Okay, so just a little bit of background here, and there's a really nice CME review article by Kari Ring from University of Virginia that came out this past month. In obstetrics and gynecology that touches on this exact subject. So I did, which is great. I really encourage everybody to take a look at that and use the citation. But I've borrowed heavily from that talk and from that paper for this talk, and included some of our certainly our background material. So in terms of endometrial cancer, uterine cancer, there's an estimated 65,000 new cases for this year, 2022, and this accounts for 7% of all women's cancers, which is the most common gynecologic malignancy that we see. Women in the United States have a 1 in 32 lifetime risk of developing a uterine cancer. And endometrial intraepithelial neoplasia, or as I'll be referring to it for the rest of this talk, EIN, is considered the precursor lesion to endometrial carcinoma, the most common subtype of uterine cancer that we see. So EIN, just a little to touch on terminology, EIN is the more now recently more commonly used terminology used to describe what was previously known as complex atypical hyperplasia historically. And so if you look back kind of in older review papers, you'll often see complex atypical hyperplasia, or CAH, referring to this same precursor lesion. There are some pathologic differences that are minor, but for all intents and purposes, when we're talking about the precursor endometrial cancer, the two are kind of used interchangeably when we're thinking about, especially these studies looking at kind of different management options for this condition. So that's a slide there from that same review article, and describing what we see in the EIN, which is an increased glioblastoma ratio and a cytologic demarcation from the background. So really differentiating that from hyperplasia in this area that is different than the kind of surrounding tissue. And then this size criteria of a maximum linear dimension exceeding 1 millimeter. Of course, this should be differentiated from benign hyperplasia, which, while there is an increased cancer risk with benign hyperplasia, the overall progression rates to a true endometrial cancer are low. And in most cases, this can be managed or cured with just medical management or even curettage. It should also be differentiated from the other precursor lesion for uterine cancer, an endometrial intraepithelial carcinoma, or EIC, which is a precursor lesion to the more aggressive uterine serous carcinoma. or the non-endometrioid histology. If you're trying to differentiate between the two, IHC with a P53 staining can help to differentiate between those two lesions. But just to really point out, EIN is truly a precursor lesion for this more common type of endometrial cancer. Historically, when we're talking about EIN, the progression rates to invasive cancer in an untreated patient were thought to be around 30%, probably a little bit lower, as subsequent studies have shown, but that number is kind of based on that classic Kerman study of following patients without treatment for at least a year before getting a hysterectomy. EIN, interestingly, has an approximate 30 to 40% rate of a coexisting low-grade endometrial cancer, or I shouldn't say low-grade, it could be a low-grade endometrial cancer at the time of hysterectomy, meaning that when you have a new diagnosis of EIN, there is a decent chance that there is going to be coexisting an early cancer as well. And this is based on one of our GOG studies. And in truth, the precursor lesion to endometrial cancer, EIN, and endometrial cancer itself do share several risk factors, symptoms and signs. Obviously, abnormal uterine bleeding being the most common symptom that we'll see. But the common, and while there's many different mechanisms to kind of get through this, the predominant one, and for the point of this talk, we'll talk about really excess unopposed estrogen, and that could take the form of either exogenous use of drugs like tamoxifen or even estradiol without progesterone, endogenous sources in the case of ovarian neoplasms like granulosa cell tumors or ovarian stromal hyperthecosis. In ovulatory states, PCOS, and we know that PCOS carries in an increased risk of developing endometrial cancer above the general population. Some estimates almost a 10% lifetime risk for patients developing endometrial cancer if they carry a diagnosis of PCOS. And then there's also genetic predispositions to developing endometrial cancer. And you may end up getting that diagnosis by first seeing a patient with EIN on biopsy. And so that includes, Lymph syndrome or HNPCC, looking at the mismatch repair genes, Cowden syndrome or P10 mutation carriers or Peutz-Jeghers. There's also reproductive factors and age. Obviously, older age is associated with risk of both EIN and endometrial cancer. And then the strongest risk factor, of course, is obesity. And just to touch on this a little bit more, obesity is the single strongest risk factor for both EIN and endometrial cancer. And just to clarify again, when I'm referring to endometrial cancer, I'm going to be referring to endometrioid type or type 1 for the purpose of this talk. So not only is it the strongest risk factor, but we know that risk rises with the severity of obesity. So the mechanisms for this relationship include chronic ovulation, the peripheral conversion of androgens to estrogens in the adipose tissue, there's decreased sex hormone binding globulin, and then the relative pro-inflammatory and metabolic changes related to obesity. And this was a nice study, a US-based case control study of looking at atypical hyperplasia, again, interchangeable in this case with EIN, but with increasing BMI, there was an increased risk of hyperplasia. So with a BMI range of 25 to 29, it was about twice the risk over the control group. BMI of 30 to 39, almost a fourfold risk. And then once you got into a class 3 obesity, the BMI greater than 40, that risk was as high as 13 times. This is another nice study looking at the severity of obesity and the relationship between risk of endometrial cancer developing with increasing BMI. So this was, again, a US-based study, a retrospective cohort study of almost 7,000 women who underwent hysterectomy and then had a subsequent diagnosis of endometrial cancer. And for each 1 unit increase in BMI, there was an associated 11% increase in the proportion of patients who were diagnosed with uterine malignancy. So you can see in this case that with increasing BMI, there was this increasing risk of endometrial cancer, really showing this kind of dose-response relationship between the two. And so, I'll touch on this at the very end of the talk too, but when we're thinking about not only patients who are at risk for developing endometrial cancer and its precursor lesion, EIN, thinking about who of our patient population is at the highest risk, so we can not only target interventions, thinking about who we should be doing endometrial biopsies on if there is abnormal uterine bleeding, but also thinking about prevention strategies for our patients who may not have this precursor lesion. What are some ways we can intervene for this population? This was one other interesting study looking at severity of obesity, and this was I really like this study. This was a registry study, or excuse me, a single institution study based out of New York, looking at the association of BMI and the age of diagnosis of endometrial cancer. And there was an inverse relationship in this case. So the higher the BMI, the younger the age of diagnosis of endometrial cancer. And we just presented some data from our own institution here that there may be a similar relationship that we're seeing actually in premenopausal patients for EIN as well, where that inverse relationship exists. And that tells us two things. Patients, one, who might be younger may still have this risk of developing an endometrial cancer or EIN. And two, as it affects a younger population, there are additional considerations, including desire for future childbearing, that we have to consider when thinking about potential treatment options for both the precursor lesion, EIN, and endometrial cancer. Oh, interestingly, in the study, this dose inverse relationship between BMI and age of diagnosis was not seen for non-endometrioid histology. So again, this is really related to these type 1 endometrial cancers, these cancers that are thought to be related to excess estrogen, as opposed to the type 2, the serous clear cell, the less common types of endometrial cancers. So I thought I would use a case to kind of illustrate some of the considerations that we should have for patients who have a new diagnosis of EIN. So in this case, we have a 36-year-old nulliparous patient in our office with a past medical history that's significant for class 3 obesity with a BMI of 48, diabetes, who's referred to us for this new diagnosis of EIN that was found on office endometrial biopsy. In this case, the patient desires future fertility, and she wants to discuss the fertility sparing options for treatment of her EIN. So if the patient in question does desire fertility preservation, now what are the goals of treatment of EIN should always include consideration of complete clearance of disease, right? Reversion to normal endometrial function to be able to support pregnancy. And then obviously the prevention of progression from the precursor lesion EIN to invasive adenocarcinoma. And not to kind of give it away here, but when we're talking about fertility preservation, the kind of best data we have for EIN, and really when we look at national guidelines around endometrial cancer, we don't have them for EIN, but we're kind of extrapolating from endometrial cancer. Hormonal management with progesterone or progestins is really the kind of best option we have for these patients. So in this case, we know that these estrogen-driven tumors or precancerous lesions can be counterbalanced by the addition of progesterone, which slows the mitogenic effects of the estrogens, induces secretory differentiation of the tissue, and can actually regress the cancer or precursor lesion back to the normal endometrium. I can end the talk right there, right? But if only it were as simple as that. So I'm just including another cartoon here, another one of my favorite rejects that monk of some kind is talking to his disciple, and he's saying, the answers to the questions you seek could also be found on Google. So as this cartoon kind of alludes to, it's not as simple as just hormonal management. There are some other considerations that we should kind of we should go through when considering a new patient with a diagnosis of EIN. So some questions that may come to mind are, what are considerations when we're counseling patients on a fertility sparing approach? Is endometrial biopsy sufficient for a diagnosis of EIN? Do we need to do any other diagnostic workup in this case? What imaging, if any, is needed here to help guide our management? And then what are the options for fertility sparing management in general of EIN? I alluded to the hormones and progestins, but what form does that take? And what options do we have to give the patient, and what are the relative advantages or disadvantages to each of those approaches? And then finally, thinking about what is the likelihood of response. How do we counsel the patient about how likely are we to be successful if we're using hormonal management? And if she does desire to be pregnancy, what is the likelihood that she's going to be able to try to become pregnant in the future? And then how do we measure this response? How are we ensured that this is a safe and reasonable approach? So just before I dive into that too much, I just want to pause to talk about the counterfactuals. So in the case where we are not talking about fertility sparing management of EIN, really total hysterectomy should be considered the standard. It provides definitive assessment of possible concurrent carcinoma, and it will treat completely the premalignant lesion, right? So again, we know that for any patient with a new diagnosis of EIN, there's a 30 to 40% chance of a coexisting early cancer. And the way to definitively rule out the presence of that cancer is through a hysterectomy and looking at that entire hysterectomy specimen for that cancer. And then if there is no concurrent cancer that is present, meaning that this is just the precursor lesion, a hysterectomy is sufficient treatment moving forward. There's without a diagnosis of an invasive cancer, there's no risk of recurrence. There's no need for any adjuvant therapy like radiation or chemotherapy or hormones following hysterectomy for that purpose, if this is just the precursor lesion by definition. So when talking about it, hysterectomy, it's important just to know that supracervical hysterectomy is unacceptable in this case. But we wouldn't want to leave behind the cervix, especially without kind of knowing definitively that there's not a concurrent cancer that's there when we have a diagnosis of EIN, because we want to be able to assess the cervix for staging purposes if there is a cancer, and we don't want to leave tissue behind that could serve as a potential source of recurrence. If we leave some of the lower uterine segment behind, for example, when we're doing a supracervical hysterectomy. For those same reasons, because that very real chance of endometrial cancer, coexisting endometrial cancer is there, we wouldn't want to subject the uterus to morcellation or cutting up the uterus. In theory, you could place this inside of a bag to be able to morcellate it, but beyond the risk of spreading tumor cells, we would also want to keep the uterus intact for the purposes of, if there is a concurrent cancer, being able to make a diagnosis of stage in terms of, is this limited to the endometrium? Is it invading into the myometrium? What is the relationship to the lymphovascular spaces? And so really, when you have a diagnosis of EIN, you do not want to disrupt or destroy the uterine specimen, and you want to keep it intact with the cervix. Similarly, treating endometrial cancer precursor lesion with an endometrial ablation is unacceptable. Obviously, again, for the risk of concurrent cancer, but then also that's not that would be inadequate treatment of the precursor lesion, and would in fact preclude the ability to repeat diagnostic biopsy to help rule out persistence or progression. Oophorectomy is not required for these patients. If we were just talking about EIN, and the performance of an oophorectomy should be tailored with the patient age, their menopausal status, and so obviously in the case of a known endometrial cancer, there is the risk of a concurrent ovarian cancer or spread to the ovaries. That absolute risk is low, and certainly for EIN in a premenopausal patient, preservation of the ovaries should be encouraged, with the knowledge that as long as the ovaries appear normal by imaging, and we'll talk about imaging, knowing that there is the option of being able to go back and retrieve the ovaries should high-risk endometrial cancer be diagnosed. What about lymph nodes? So this is a question that is that has come up, especially in the last few years in a lot of our kind of national meetings about when we have a diagnosis of EIN and the patient does not desire fertility sparing, and we go forward with a hysterectomy, is there any value of doing lymph node assessment at the time of that surgery? And certainly, if for a preoperative diagnosis of EIN, doing a full pelvic and periaortic dissection is unnecessary and would way overtreat precancerous lesion. If EIN has no risk of going to the lymph nodes. What you're trying to balance here is the risk of a concurrent high intermediate or high risk carcinoma that may be present, right? And when there is a endometrial cancer that's there, that risk may be as high as 10%, right? So some strategies that providers have used and within our own practice, myself and my partners that have utilized is use of either frozen section, so doing a total hysterectomy, sending the uterus to the pathologist to look for any evidence of invasive carcinoma, and then if there is invasive carcinoma, characterizing that according to risk of size of the tumor, the depth of invasion, the grade of the tumor, to help inform whether a lymph node assessment should be performed at the time of hysterectomy for what was presumed EIN and now turned out to be a cancer. And what that allows the surgeon to do is mitigate the risk of needing to go back for a staging lymphadenectomy after it's revealed to be a cancer on final pathology. Frozen pathology has a pretty high correlation for histology, grade, and depth of invasion, so all above 95%, apart from grade, which can vary a bit between the frozen and the final. But I guess it's really important in these cases to kind of know your own institution's capabilities for frozen pathology, know your own kind of capabilities for being able to take patients back if they do need a staging lymphadenectomy, and have that conversation with the patient preoperatively to be able to consent them for a staging lymphadenectomy should a high risk or high intermediate risk cancer be diagnosed at the time of surgery for EIN. Other strategies have been proposed to kind of be able to still do a lymph node assessment, but spare the putting the patient through a frozen section and then a lymphadenectomy, because with a frozen pathology that shows a high-risk cancer, you're now committing the patient to a full lymphadenectomy, removing all the lymph nodes in the pelvis and the periodic region to make that assessment of the lymph nodes. Sentinel lymph nodes have really replaced what we do for lymph node assessment in endometrial cancer, and there are some advocates for using sentinel lymph node mapping and biopsies for EIN as well, especially in those cases where the preoperative biopsy may say EIN cannot rule out invasive carcinoma, or higher risk patients with a, let's say, with a known genetic predisposition, or have some preoperative factors that make us more worried about a final diagnosis of endometrial cancer. So that would include some studies have shown that endometrial stripe thickness on preoperative transvaginal ultrasound may be related to the risk of a patient having a subsequent diagnosis of endometrial cancer when they go to the operating room for a hysterectomy for EIN. So sentinel lymph nodes do offer a kind of different option in the modern era of staging surgery as well. I didn't put this on here, but just as another note, salpingectomy should be performed with every hysterectomy. There's no point in keeping the tubes for a patient who is no longer going to be pursuing childbearing, and obviously there's the benefit of reducing the risk of a fallopian tube carcinoma or early ovarian carcinoma too. Okay, going back to our case here, sorry for that detour. So our patient wants to discuss fertility sparing options. And so we're talking with her about what are the considerations for counseling when we're thinking about this approach. So a few kind of general points is, what is the patient's own reproductive history, her age? Is it warranted to put in a referral to reproductive endocrinology? Is this patient nulliparous, but she's been trying to become pregnant for the last decade and a half? Has she had a diagnosis of infertility before? Is she multiparous? Has she had many children before? And there's low concern for for that being an issue. Age also, right? If the patient is perimenopausal, obviously the counseling around future childbearing or fertility sparing approach would be different for a patient who is in her 20s and her 30s, early 40s, perhaps. And so really in this case, involving our reproductive endocrinology colleagues, I think, is important for these patients, especially when we may be dealing with some patient factors that may influence their ability to become pregnant in the future. Family history, doing a thorough family history to rule out hereditary cancer syndrome. So of course, for patients, we know again, there's that risk of subsequently diagnosing a concurrent cancer. And so for patients who are younger, certainly we have to consider, is there a reason beyond this excess estrogen exposure that she may be developing this condition? And ruling out things like Lynch syndrome, or at least assessing her risk of a genetic cancer syndrome by doing a thorough family history is important here. Obviously, that knowing that the patient is a mutation carrier for hereditary cancer syndrome may also influence her conversations with a reproductive endocrinologist around childbearing, IVF, and so forth. Another consideration would be contraindication to hormonal management. Well, rare, and depending on what type of hormonal management that is, but depending on kind of which route we go, and we'll talk about that in just a minute. If the patient, for example, has had an adverse reaction to using a progestin in the past, or a certain method of progestin in the past, that may be kind of worth sussing out as part of your initial assessment. And then, of course, medical comorbidities, right? So, in this case, the patient has a BMI of 48, diabetes, kind of understanding that no matter what we do, the driver of this condition of the precursor lesion is likely related to this exogenous estrogen exposure, and she's still going to be at risk for this, even if we can do a conservative management approach where we can get this to go away for some time to be able to get her pregnant, and especially because of our high success rates in being able to treat this. Some of these comorbid medical conditions may be of a greater threat to this patient than the precursor endometrial cancer lesion. And so if your institution offers it, as Beth Israel does, if there's a weight loss management center, either for discussion of medical management or surgical management, and obviously the scope of this talk isn't going to kind of go into all the different weight loss strategies, but referral to a center, if that's offered, is a encouraged approach in this case. And then along with that, when you're thinking about medical comorbidities, is thinking about is there a benefit of discussing with your maternal fetal medicine colleagues at high risk obstetric group. So if you are successful in treating this endometrial cancer precursor and the patient goes on to become pregnant, what are the risks of that pregnancy to the patient with her medical comorbid conditions? And in this case, I listed the BMI and diabetes, but if the patient, for example, had in addition to that major cardiac medical comorbidities that would be life-threatening should you become pregnant or so on. You can kind of play that out. It may be worth it to have a formal assessment of maternal fetal medicine to for the patient to be counseled about what that risk would be if she were to become pregnant. So she could make the best decision about how to manage this, this precursor. The next topic, just to touch on here, is then this diagnosis that was made for this patient is by endometrial biopsy, so an office Pipel biopsy. And is this sufficient in this case? And by sufficient, I mean not only is it sufficient to make the diagnosis of EIN, but also to rule out the presence of a concurrent endometrial cancer, right? Because although the management for fertility sparing approach may be similar, the response rates for our hormonal management are different between patients who have an endometrial cancer and a precancerous lesion. And so knowing that up front, as best we can, ruling out the presence of a coexisting endometrial cancer is important to be able to counsel the patient best on the likelihood of success. And also for the patient's perspective, just knowing that the presence of the cancer may influence her decision to proceed with a fertility sparing approach versus definitive hysterectomy. So there is some controversy. When we talk about what are the options, the kind of two big modalities that we think about are either going to be an endometrial biopsy, office Pipel biopsy, as I mentioned, or dilation, hysteroscopy, DNC, dilation and curettage, right? We can do that in some offices or in the operating room. Important to know, there's no consensus guidelines, no kind of national body that will tell us which one to use for EIN. We know that the NCCN, the National Comprehensive Cancer Network's recommendations for fertility sparing management of cancer is for doing a DNC. But neither procedure guarantees the absence of a cancer on the final hysterectomy specimen, right? So whether you do one or the other, even if you're only finding EIN, there's still that risk that exists of finding an incidental cancer post-hysterectomy, or there being an incidental cancer that's present that isn't diagnosed until definitive management is performed. So I've included here a few studies. The data is not great. There's a meta-analysis that I'm citing here, and then a few single institution retrospective studies. The meta-analysis I included here because there may be a difference in sensitivity for endometrial biopsy of diagnosing an endometrial cancer in a patient in premenopausal patients compared to postmenopausal patients. So, in postmenopausal women, that EMB is pretty reliable for being able to detect that endometrial cancer, or more reliable certainly compared to a premenopausal patient, and knowing that endometrial biopsy, like dilation and curettage, is only going to sample a portion of the endometrial cavity, you may be missing that focus that includes the endometrial cancer. And then two studies here, one from Memorial Sloan Kettering and the other from MD Anderson, looking at nearly 200 and then 150 patients respectively, and patients with EIN or CAH, again, that nomenclature has changed over time, preoperatively, who then have gone on to get a hysterectomy. And I'm looking back and saying, did the histology differ? Did the pathology differ on final pathology of the hysterectomy compared to our pre-op biopsy saying there was EIN? How was that biopsy made? And in the case of the Sloan Kettering series, the office Pipel biopsy diagnosis of EIN was then found to have 2.5 times more likely to be associated with a incidental finding of underlying carcinoma on the final specimen. So meaning that if a patient had a biopsy compared to a DNC, you were more likely to find cancer on that final hysterectomy specimen. Another way of saying that, I guess, would be you're more likely to find that cancer preoperatively by doing a DNC, at least based on this series, and the final author on this this next series, Michael Fromowitz, was in agreement. So again, you were more likely to find endometrial cancer if you had an office pipelle biopsy before hysterectomy, a DNC specimen before hysterectomy compared to an office pipelle biopsy. Again, the relative volume of sample for both of these modalities is small, and so that's why you have the potential missings. And so there are some who advocate for using a hysteroscopic assessment with your DNC to be able to target abnormal findings on hysteroscopy of what you should be biopsying to know that you're not going to be missing a significantly abnormal appearing area and ruling that out as a source of potential concurrent cancer. So again, while we don't have great consensus data, the NCCN preference is for in the case of cancer, is for a DNC, and so it's reasonable to extrapolate for EIN to similarly do the same, to be able to kind of best rule out the existence of a concurrent cancer. Of course, the other thing to point out is if you were planning on doing a hysterectomy, this matters a little bit less, right? I mean, it's good to know about a cancer diagnosis beforehand, so you can, potentially do sentinel lymph nodes if that's your plan. You can counsel the patient about the staging surgery and so forth. But ultimately, you're going to be removing that cancer. If you're not going to be doing a definitive hysterectomy and you miss a diagnosis of endometrial cancer, again, we know that response rates to hormonal therapy are a little bit worse, and so you may lose the opportunity to appropriately counsel patients on the likelihood of them having a successful regression of this precursor lesion. So going back to our case, we would ask, do we need any imaging for this patient? So, they have an office endometrial biopsy. Based on our last slide, we were just having to go back for a hysteroscopy DNC just to give our best shot here of ruling out a current endometrial cancer. Is there any imaging that's going to help us here make that difference in diagnosis? Well, there is some data from our own institution here that the on ultrasound that the thickness of endometrial stripe may predict patients who are at higher risk for concurrent endometrial cancer. The thicker the stripe, and there's some different kind of cutoffs associated with that with higher risk. We know that with an ultrasound in general, it's lower cost compared to something like an MRI. It's easier performed. It's easier to get kind of patients scheduled in an expeditious fashion. And in truth, many patients who come to you with a new diagnosis of EIN would have already obtained a transvaginal ultrasound at the time of the clinical evaluation. I think it's important to have some imaging here, and the other point about a transvaginal ultrasound is you can adequately assess both the tubes and ovaries to rule out any concurrent ovarian pathology at the same time. If endometrial cancer is diagnosed, whether on your DNC that you would do subsequently for this patient, an MRI can help to evaluate for myometrial invasion, to tell whether this is maybe a higher risk cancer. Cervical invasion, obviously we can upstage the patient or evaluate the nodes for any enlarged nodes to best be able to counsel the patient about kind of risk of higher stage disease. And that sensitivity is high. And there's not great data around that, but from what we can tell, an MRI is probably going to give you more information for those patients who have a cancer preoperatively. So in this case, I would say, as long as we have a transvaginal ultrasound, that should be sufficient. So now let's get into kind of what are the options for fertility sparing management of this precursor lesion, and what is the likelihood of response and how we measure it. And this is a great ACOG committee opinion that was originally from 2015, but was reaffirmed just a few years ago. And they have this great table that summarizes, and you'll see this table in other review articles around EIN or hyperplasia. Options for the hormonal agent, Again, these are all progestins, they're synthetic progesterones, and the dosage and then the length of treatment. And just so you can see here, obviously there's quite a range, right? So for your Megace and the megestrol acetate, the range of treating patients, 40 milligrams per day up to 200 milligrams a day or more in some studies actually. For Provera, same thing, this wide range. And that's because there's, a lot of the studies that we have on using this for endometrial precancers or precursor lesions have included a wide kind of very heterogeneous group of either type of progestin that's used, the route, and the dose. And so there's no consensus on a single standard regimen to use. There are probably more common ones, and I'll just touch on that briefly. The other complicating factor when you're reading about conservative management or using hormones to manage EIN, not only the risk of concurrent cancer that's either going to be diagnosed subsequently or is present, but they will often combine series of patients who have EIN or precancerous lesion and low-grade endometrial cancer. And so teasing out the success rates of these relative regimens does require you to kind of read through the series and parse out which patients are included in the study. And the reason I mentioned that, and I'll point to this in our next slide, is your response rates tend to be higher with EIN or the precursor lesion compared to endometrial cancer. Even though they share several risk factors, the same mechanism of development, they seem to respond very differently to these treatments. This is a very large systematic review from a few years ago that looked at 45 studies. Again, kind of a range of different approaches or routes and types of progestins, and looked at both oncologic outcomes, reproductive outcomes. In this series, the median age was around 31. They included both EIN and endometrial cancer in this systematic review. The median time to complete response was around 6 months, and that's, you'll see that come up in subsequent studies too. The majority of patients in this systematic review did use oral progestins, and only about a fifth of patients utilized the IUD. And I just point here to look at the kind of overall complete response rates, which is actually a bit lower than what you'll see in some of the next slides I'll show, about a 65% complete response rate for EIN for patients who are using progestins, which is better than the endometrial cancer response rates for using hormones in this series. And about a quarter of those patients, almost a quarter of those patients for EIN ended up having a recurrence or a relapse despite having that complete response. Again, that's low for what we'll see in the next few slides, and I attribute that mostly because of the kind of range of different progestins, the range of dosing, and so we didn't really there's not quite a standardized kind of approach in this case. I will also point out the proportion achieving pregnancy and the number of live births, and this is something that comes up in some other papers too, but for quoting patients, what is the likelihood of achieving pregnancy? A lot of studies will point to this number around 30 to 50% for hyperplasia, a little bit lower for endometrial carcinoma. That is going to be influenced by not all patients who undertake a fertility sparing approach will go on to then try to become pregnant. And then in terms of the live birth rate, most studies will point to about 10% lower in this population. So, and that for obvious reasons, the live birth rate is going to lag behind the proportion who achieves pregnancy. When thinking about that table, and you're thinking about using an oral progesterone for your patient or offering that, probably the two more commonly used, medroxyprogesterone and megestrol, which one to use or which one to offer or utilize. There's no prospective studies comparing these two drugs, two regimens, two doses, and they're generally thought to be equally effective or interchangeable. Megace is probably more commonly used in the literature. Usually prescribed in my own practice, around 160 milligrams per day in divided dosing. Usually that's BID dosing. Response rates overall for both of these drugs are typically around 80%, maybe a little bit more for EIN, for the precursor lesion. Again, that's going to be a little bit lower in endometrial cancer. The thing to kind of counsel patients about when using oral progestins in general is that this is a systemic treatment, right? So there are side effects that are associated with oral progestins that you may not see with, for example, the progesterone IUD, the levonorgestrel IUD, which is really a local treatment. So some of those side effects may be significant: nausea, mood changes, irregular vaginal bleeding, theoretic and real, risk of VTE, and weight gain, which is probably the number one discussion point I have with my patients who are on oral progestins. Is many of these patients who have EIN or the precursor lesion are obese, and they're worried about gaining more weight while on this treatment. The adverse effect profile may affect the compliance, so non-compliance can be an issue too when using oral progestins. So with these side effects, it's the other question is kind of efficacy in patients who do have larger BMIs too. Are you getting the same effect for patients who is the pharmacokinetics the same? The levonorgestrel IUD for the progesterone impregnated intrauterine device allows you to bypass those systemic risks or the adverse effects related to systemic treatment. So you lose that weight gain is not present. There's a relatively small amount of level that reaches kind of the blood, and so those other effects, nausea, mood, we just don't see with levonorgestrel IUD. This was a really nice prospective trial from Dr. Weston, looking at patients with both endometrial cancer and CAH-EIN using the levonorgestrel IUD. In this case, the median age was 48 and the median BMI was 45. She included in this study both patients who were utilizing a fertility sparing approach, meaning that they were younger and trying to preserve future childbearing, and also patients who were medically unable to go for a hysterectomy, which is why that median age is a bit higher than you'll see in some other series. But the complete response, if you look at the CAH column there, it's really high, so 91%, so really good. And again, this is likely related to the fact that, and I'll point this out next slide, that you're getting a lot of that dose of progesterone right where you want it, in the uterus, in the endometrium, where that precursor is. The adverse effects on this trial were very mild. Again, irregular bleeding, cramping, quality of life was unaffected by having this the IUD in. Most patients responded by 3 months, so about more than 3/4 at that 3-month mark. And then there was additional patients who responded with each subsequent assessment. And in this study, and as I'll mention, reassessments of disease status were performed on 3-month intervals with repeat biopsy. 2 other studies that kind of highlight the effect of the levonorgestrel IUD on precancerous lesions of the endometrium. So in this case, this Gallo's 2013 study was a large population-based UK cohort study with a long 12-year follow-up. They compared oral progestins in conglomerate to the levonorgestrel IUD. There was a 94% rate of regression compared to an 84% rate of regression favoring the use of the levonorgestrel IUD. Interestingly, the failure to regress and the likelihood of recurrence was associated with those patients with higher BMI. And then I included here, there's many studies like this. And so this is just one example, a single institution retrospective study looking at, again, EIN, CAH, treating with progestins, comparing the levonorgestrel IUD to systemic progestins or oral progestins. And there was, again, a higher rate of response with the levonorgestrel IUD. And this study did point out that there was a greater benefit for those patients who had class 3 obesity for using the levonorgestrel IUD compared to class 1 and 2, likely related to some of those pharmacokinetic differences for patients who are with higher BMIs compared to lower BMIs. And so with the IUD, you can kind of bypass that because you're, again, giving the drug right to the uterus. In terms of the follow-up and surveillance, you'll see a pretty wide range within the literature. There's no consensus, again, or national guidelines for EIN specifically, but the NCCN does suggest a 3 to 6 month interval assessment for endometrial cancers. And so we can extrapolate for EIN. In my own practice, we do the same. So every 3 months to 6 months, we would repeat a sampling of the endometrium. Endometrial biopsy is less costly, easier to do in terms of scheduling. You're not putting the patient under anesthesia for it. You can still give adequate pain medication in the office for that biopsy, or pain control for that biopsy in the office. And so doing an EMB here is reasonable to do. If there is concern about persistent EIN or progression, I think it's reasonable to move up to a DNC, but EMB should be sufficient for those interval assessments of response. Again, we saw that the majority of patients on prior studies have responded 3 months, 6 months, and certainly if patients have not responded by 6 months, you should be concerned or at least thinking about is this patient not going to respond to treatment, and having that discussion with the patient early about what are some other alternatives. There's no consensus on how to transition patients for attempting pregnancy off of the progesterone they're on. Some providers will advocate for, if you have a complete response, repeating that biopsy at least one more time to ensure that the precursor lesion is cleared, and you have a complete response, and then immediately going on to try to become pregnant. And this is where really working with our reproductive endocrinology colleagues is beneficial or helpful to be able to kind of best transition to trying to become pregnant, certainly soon after. If you do achieve a complete response through hormonal management, whether it's through oral progestins or the IUD, the patient's not ready for pregnancy, the progesterone could be continued, or should be continued rather, because there is that ongoing risk of relapse. There's no consensus for kind of the use of dual therapy here. So for example, adding on progestins, but I will say that is, it is described in the literature, and it is used in practice as well, that if patients are non-responding to the IUD, adding on oral progestins, again, data-free zone, but may show some benefit in helping to control or achieve regression where you otherwise would not have been able to. When do we consider hysterectomy? If there's not been a response at 6 to 12 months, certainly in my own practice I would say 12 months is reasonable, as long as you're not seeing any evidence of progression on these biopsies. You should consider proceeding with definitive management. Again, there's not really great data to suggest kind of adding on additional hormones, but dose escalation is reasonable, considering that there may be a better response, especially for patients who may be at risk of not responding as well to oral progestins. Certainly, if there's a relapse, they have a complete response and it comes back, it's reasonable to consider hysterectomy or progression. So you're biopsying, you have EIN persistent, and then a biopsy that then shows progression to a low-grade endometrial cancer. Certainly, it's reasonable at that point to say this is not working, we should proceed with a hysterectomy. I mean, tantamount to this fertility spring approach is really counseling patients appropriately on the fact that a lot of what we're doing for EIN and using this approach is extrapolated from kind of NCCN compendium listed guidelines around endometrial cancer. And so we want to try to keep patients safe and do these assessments at the interval to be able to switch gears and offer them a hysterectomy in the case that we're worried about this is not working and there's a risk of progressing to an adenocarcinoma. And then certainly completion of childbearing, right? So if the patient is, you've had a complete response, the patient goes on to get pregnant, she no longer wants children after delivery, it's reasonable then to proceed with a hysterectomy at that point, because likely whatever put her at risk of developing EIN before that pregnancy is still going to be there after delivery. Some other studies have mentioned here or talked about some other strategies. So in the case where you have a relapse or a stubborn lesion that is not responding, what about hysteroscopic resection prior to hormonal treatment, or putting in an IUD? What about the use of GnRH agonists or metformin? Nothing is really kind of the data has not really borne out for these approaches, particularly with metformin. There's been some mixed data. It seems like the pendulum is swinging a little bit more in favor of it. More recently, there's been a Cochrane review in 2017 that cited insufficient evidence to support its use in combination with progestins for EIN or hyperplasia. I don't think anybody would argue for metformin use alone in this condition. It would be used as an adjunct to progesterone treatment. More recently, some reviews have suggested there may be a benefit to adding on metformin. In this randomized controlled trial from China of 150 patients, the use of metformin, patients had an earlier and more frequent rate of complete response compared to patients who are on megas alone. And in fact, we may, whether patients, because they have a diagnosis of PCOS or diabetes itself, they may be on metformin already in these cases. It does not appear to cause harm. Finally, just to talk a little bit about prevention here, this is my last slide before I'll pause for questions, is again, the obesity is probably the strongest risk factor here for this condition. When you take out the patients who have an exogenous or an endogenous kind of source of estrogen or estrogen exposure. And so counseling patients about weight loss, as I mentioned, referral center to a weight loss center, but there is some data that bariatric surgery is associated with improvement of endometrial precancerous conditions, and that the baseline risk of patients who present for bariatric surgery is high. So up to 10% will have some diagnosis on the hyperplasia spectrum. Thinking about prevention too, use of progesterone seems to be protective, or exposure to progesterone is protective. If you think about it with the patients who are at risk because of anti-ovulatory reasons, this makes sense. And there's some population-based studies that have shown that 5-year use of OCPs, particularly in the PCOS patient population, or there's some great studies from Scandinavian countries, of 5-year use of the progesterone-containing IUD is associated with around a 50% reduction in the development of endometrial cancers, and that benefit of using those prevention strategies likely extends beyond the 5 years of using that treatment. And so, thinking about your patients who may be at highest risk, whether they are PCOS, class 3 obesity, potentially have some exposure to unopposed estrogen, really considering, is there an opportunity to utilize progesterone in the form of a levonorgestrel IUD that may reduce the patient's risk of going on to develop EIN and endometrial cancer. This is my last slide here. I always worry with these talks that by oversimplifying things that I kind of lose the point of what I'm doing. This is a joke that I wrote with one of my good friends, Alex Pearson here. It's a juggler throwing up one ball, and the caption is reading "decluttered juggling," and it's just about when you oversimplify things. Sometimes you lose the kind of message you're trying to create. So I hope I didn't do that today, and I hope this was helpful. And I will stop for some questions. But thank you for your time and your attention.